Welcome to our high-yield review of herpes simplex virus. We're going to cut right to the chase and give you exactly what you need for your exams. No fluff, just the core concepts that will help you ace your test. So we're going to follow the virus like a detective story. First, we'll look at the invasion, how it gets in and what it does. Then, the investigation, how we actually diagnose it in the lab. And finally, the counterattack, how we treat it. Let's get started. Okay, first up, pathogenesis. This is all about the enemy's game plan. How does herpes simplex virus breach our defenses and set up a permanent base of operations?
So here it is, our target. It's a big, enveloped virus with linear double-stranded DNA inside. But for your exams, the most important part to focus on are these little glycoprotein spikes on the outside. You can think of these as the virus's own set of lockpicks that it uses to break into our cells.
Now, this virus has a really sneaky 5-step plan. It doesn't just infect and leave. First, it gets in through a little break in the skin. Then, it starts multiplying right there. Step 3, it invades the local nerve endings. And here's the clever bit. It travels backward, that's retrograde transport, all the way to the dorsal root ganglia. And step 5, the most crucial part, it just goes dormant. It establishes a lifelong latent infection, which is exactly why herpes can pop up again years later. Telling the difference between HSV-1 and HSV-2 is a total classic for exams. The easiest way to remember it is this. HSV-1 is usually spread through oral contact and causes infections above the waist, like cold sores. HSV-2, on the other hand, is usually sexually transmitted and causes problems below the waist. Now, it's a generalization, but it's a super high-yield one. This table right here is pure gold. It lays out all the high-yield details you need. Notice the different places they go latent. We're going to talk more about that in a second. Also, look at the different things they can cause. HSV-1 is linked to nasty encephalitis, while HSV-2 can cause really dangerous neonatal herpes. And, for the clinic, this is huge. Drug resistance is more common with HSV-2. Seriously, you might want to screenshot this one. It's perfect for a last-minute review. Okay, remembering where each virus likes to hide out, where it establishes latency, is non-negotiable for your exams. So I've got a super simple visual mnemonic for you that I promise you will not forget. All right, for HSV-1, just look at the number 1. If you draw a little line on the top and bottom, what does it look like? It looks like a capital T. And T is for trigeminal ganglia. And where's that? It's in your head, exactly where these classic oral and facial lesions of HSV-1 show up. See? Simple. So what about HSV-2? Well, just look at the number 2. It's shaped just like an S. And what does S stand for? Sacral ganglia. The sacral ganglia are down in the lower spine, which lines up perfectly with where HSV-2 infections typically happen. It's a dead simple visual trick, but trust me, it works. Okay, so we know the virus's strategy, but how do we actually catch it in the act? Time to move on to the investigation, lab diagnosis. The classic first-line investigation is often something called a Tzanck smear. We just take a little scrape from the base of a sore, put it on a slide, stain it, and look for this classic sign, a multinucleated giant cell. You might also hear it called a Tzanck cell. The second you see this under the microscope, your brain should be screaming herpes virus. So what are we really looking for on that smear? Well, there are 4 key signs that are a dead giveaway for a herpes virus infection. First, those multinucleated giant cells we just saw. Second, you might see something called Cowdrey type A intranuclear inclusion bodies. Just think of them as little virus factories inside the cell's nucleus. Third, the infected cells start to swell up or balloon. And fourth, the cell's DNA, the chromatin, gets pushed to the edges of the nucleus. This whole group of findings is a hallmark of both HSV and varicella zoster virus. Now, besides the smear, we have a whole modern toolkit. PCR is our most sensitive test. It can find tiny amounts of viral DNA and can even tell HSV-1 and 2 apart. But the real gold standard, the most definitive test we have, is virus isolation. This is where we actually grow the live virus in the lab and watch it damage cells. It's the ultimate proof. So we've identified the enemy, we've confirmed it's there. Now it's time to launch the counterattack. Let's talk about treatment. Our number 1 weapon against HSV is acyclovir, and the way it works is just brilliant. It specifically targets and shuts down the viral DNA polymerase. That's the enzyme the virus absolutely needs to make copies of itself. Our own cells are totally unharmed. So if the virus can't copy its DNA, it can't make new viruses. Game over. Now, this table is super important for your exams because treatment is not a one-size-fits-all deal.
For your standard skin infections like cold sores or genital herpes, oral drugs like acyclovir are perfect. If the infection is in the eye, we use special topical drops. But, and this is a big but, for life-threatening infections like encephalitis or in a newborn, we go in with the big guns, high-dose intravenous acyclovir. We need to get those drug levels up, fast.
Okay, but what happens when our main weapon, acyclovir, just stops working? Acyclovir resistance is a real and growing problem. We especially see it in patients with weak immune systems. And as we saw earlier, it's more common with HSV-2. So what's our plan B?
And that brings us to our final, critical takeaway. This is a clinical pearl you need for your exams and for your future practice. When you're faced with acyclovir-resistant HSV, the next drug you should think of is Foscarnet. Remember that name, it's your go-to second-line drug. And that's it for your high-yield review of herpes simplex virus.